Kentucky Task Force, and those of you that are looking at the agenda know that we have a very robust agenda today, so we will be, in the interest of time, kind of trying to move through these items expeditiously. Before we get going and before we call the roll, we do want to acknowledge the tragedy in Louisville that occurred yesterday with the UPS plane. And so we want to keep those members and their family in our prayers. And so we are going to take a moment of silence before we get started today just to remember them. Thank you. I also want to remind our members as well. Of course, this is our November meeting, and so I would encourage you between now and our December meeting, which is December the 16th at 9 o'clock in the morning. If you would, please submit to your co-chairs any type of recommendation that you have from our task force in terms of policy recommendations. You can email those, and then in our December meeting, we'll be talking about our report that we'll submit to LRC. So make sure and get those submissions and recommendations into us so that we can discuss those in our December meeting. So as we get started, please call the roll.
Senator Chambers Armstrong. Senator Douglas.
Present.
Senator Richardson. Here. Senator Wheeler. Here. Representative Callaway. Representative Duvall.
Here.
Representative Moore.
Here.
Representative Proctor. Co-Chair Funky Fromeyer.
Present.
Chairman Lockett.
Present. All right, we do have a quorum, and so we will continue with the approval of the minutes from the October meeting, which is in your folders. Do I have a motion for approval?
Motion to approve.
I have a motion. Do I have a second? Second. All of those in favor say aye.
Aye.
All those opposed? All right, the minutes are approved from the October 15th meeting. So our first presenters today, if you would, go ahead and come to the table. We're talking about tobacco, nicotine, and vapor products. And so we have Miss Elizabeth Good and Julie Brooks. If you would, please make sure that your light is bright green on the microphone. Introduce yourself. We are going to allot about probably 5 to 7 minutes or so for a testimony. And I will point out to our members as well, we are not taking questions on this section. This is just only for information, so please continue.
Good afternoon. I'm Julie Brooks, the Policy Specialist with the Department for Public Health.
Good afternoon. Good afternoon. I'm Elizabeth Good. I'm the Director of the Division of Prevention and Quality Improvement at the Kentucky Department for Public Health. I want to thank our chairs and committee for inviting us here today. The Kentucky Department for Public Health houses the Kentucky Tobacco Prevention and Control Program. And I've been asked to talk today to you all about vaping, and first of all, in regards to a recent report that was released by the Office of the Surgeon General in partnership with the Smoking and Tobacco Use Advisory Committee. This September 2025 report, it was on youth vaping and called Sound the Alarm, Youth Vaping Can Harm. Again, it was released in September of this year, and it shared some very important information in regards to the dangers of youth vaping. Half of products on the market today are not actually authorized by the FDA, and the majority of products used by teens are flavored. Once vaping, teens are also much more likely to use other tobacco products. There's many negative impacts of vaping by youth. It can affect brain development, worsen mental health issues, create risks for developing chronic diseases, lung damage. It can exacerbate asthma and disrupt hormones, among other risks. We do survey about the use of vaping tools here in Kentucky. One survey is the Kentucky Youth Risk Behavior Survey. I'm going to share a little data from 2023. In that year, our data showed that 8.7% of those students surveyed reported daily use of vaping products, and 19.7% surveyed report using at least one day in the last 30 days. We do have proven interventions for preventing youth vaping, fortunately. One important one is called Catch My Breath. It's a peer-led teaching approach which empowers students with the knowledge and skills needed to make informed decisions about e-cigarettes and how to reduce and resist social pressures to vaping. The Catch My Breath program works towards helping children in grades 5 through 12 and consists of 4 unique lessons for each grade group. They're about 35 minutes each. It's the only school-based vaping prevention program that's proven to reduce the likelihood of vaping among youth, but we do have some other programs that are promising and show great data for prevention. Importantly, in the 2021 school year, legislation went into effect to prevent smoking on school campuses, and notably it encourages non-punitive interventions for violators. I Can End the Trend is an evidence-based program developed by the University of Kentucky. It's used by researchers and students. Presentations are made to grades 4 through 12. Since 2019, we've reached over 150 schools in 75 counties and more than 30,000 students here in Kentucky. 85% of high school students say they learned something new, and 90% thought that they think it is helpful for someone their age to take the course. Now, those are resources for preventing vaping, but we also have resources for quitting youth vaping. Not On Tobacco is an in-person cessation program for youth. It provides 50-minute sessions weekly over 10 weeks, and there's various settings. 90% of teens using this program report cutting back or quitting. Secondly, there's My Life, My Quit and Quitline services. It's a free and confidential resource. You can text to initiate the program. You utilize an app, which is very popular, to set goals and track your progress. And I do want to share that there is a tobacco retailer education program available in Kentucky Trust. It was created in partnership between the Department for Public Health and the Department of Behavioral Health Development and Intellectual Disabilities. It's an online self-paced module with a quiz, and it goes over things like state and federal laws around tobacco sales, what to look for on IDs, and how to refuse a sale without inviting conflict. In 2024, 3,701 individuals trained in Trust, and we distributed 253 Tobacco 21 toolkits. It has been very well received and helps with de-escalation with customers when they're denied sales. Thanks so much for your time today.
Thank you so much. We appreciate your testimony. So next we will hear from the Department of Alcoholic Beverage Control and Licensing, Scotty Tracy and Jamar Carter. If you would please come to the table. Please identify yourselves and you may proceed. Please make sure your mic is on.
Good afternoon. I'm Scotty Tracy. I'm the Commissioner of Kentucky ABC.
And I'm Jamar Carter, the Executive Advisor for the Tobacco Department.
Mr. Carter, I don't think your mic is on either.
Jamar Carter, the Executive Advisor for the Tobacco Department of the Alcoholic Beverage Control.
Thank you.
ABC is here today to provide a quick update on Senate Bill 100 implementation related to the creation of the Division of Tobacco, Nicotine, and Vapor Product Licensing. SB 100 was passed during the 2025 regular session and requires all retail business in the Commonwealth of Kentucky selling tobacco, nicotine, or vapor products to be licensed by the Kentucky Department of Alcoholic Beverage Control. No retailers are expected from this exempted from this requirement if they sell any of these products. As part of its implementation, ABC was tasked with promulgating regulations for SB 100. These regulations were filed with the reg compiler on October the 31st, 2025, and may also be found on the ABC website. Additionally, an application portal has been created and can be found on the ABC website. This application portal is now live for businesses to complete the licensing application online.
All right, thank you. I actually, if you would, one of the problems that we have kind of goes back to our prior testimony as well. One of the problems that we have in this state is that we have retailers, a lot of retailers that sell to minors. As a teenager, you can walk into a lot of gas stations, and even if there's a fine for selling to a minor, they just pay it and move on because the fine is less than the revenue that they get from selling. So could you speak to enforcement of the law of SB 100, enforcement of retailers that are selling to minors?
To your point,
Could you pull the microphone closer to you?
yes, I'm sorry. Violations if sell under 21 have fines in place. First offense is $100 to the clerk who sold product and notice to the owner. Second offense, $100 to the clerk and $500 to the owner. For third violation, $100 to the clerk, $1,000 to the owner. And upon fourth violation, no renewal of license for 2 years. Unpaid fines will also cause non-renewal of license until paid. I do know enforcement is out actively working to identify the sales to minors.
What is the process if a parent or if someone knows of a store, gas station, convenience store that is actively selling to minors? What's the process that a parent or someone can go through to report that particular convenience store?
They can report that on the portal. They can call. They can go on the ABC website. Once that is reported, we forward it to enforcement, and then they proceed.
So in enforcement then does what? Once they receive a report or a tip, if you will, then what happens?
They would go investigate, obviously, and try to see if they're selling, or try to see or work with someone to see if they can purchase underage.
Do you happen to know the average? Do they investigate all tips that come in?
It's my understanding they do.
Okay. All right. All right. Thank you very much. We appreciate your testimony. Thank you so much.
Thank you for having us.
Just a note to members as well, you do have a press release from the American Lung Association in your packets from a particular report. Kentucky is the worst in the nation for new lung cancer cases, second worst for adults who smoke. So please make sure and take a look at that and read over that as well. So we will move on in our meeting today with our functional medicine, and I would call Ms. Kimberly McKenna to the stand, please. And if you would, again, just like all the rest of them, make sure your green light is on the microphone, and please introduce yourself, and you may proceed.
My name is Kim McKenna Johnson. Sorry, my name is Kim McKenna Johnson.
Shayna Seaborn, nurse practitioner at One Cross.
Before you keep going to, I just want to make a note to our members as well. There's a folder that's in your packet from One Cross Community Health. Please proceed.
Thank you. Chair Lockett, Chair Funky Fromeyer, and distinguished members of the Assembly, thank you for the opportunity to speak today. Your work in this chamber directly impacts the health of every family in Kentucky. Decisions you make echo through generations, our schools, our communities, and our healthcare systems. What you do matters profoundly. As legislators, you have the unique power to transform how we approach healthcare in our state. Today, I'm here to support your mission and of creating a healthier Kentucky by sharing insights that could fundamentally change how we approach health and wellness in our rural communities. My name is Kim McKenna Johnson. I'm founder of One Cross Community Health. We are located in Taylor and Marion counties. We have 2 locations and we serve over 7,000 unduplicated patients. We opened in January of 2015 with me, a nurse, and my 17-year-old daughter. The need was great. At that time, Taylor County was not designated as medically underserved, so there was nobody that was taking care of those that didn't have insurance or those that had Medicaid. They had to go to the ER for care or out of county. So One Cross had a big mission, and our mission was that we offer high-quality health care of body, mind, and spirit to always serve because Jesus is the healer. So that initial mission that we had was a holistic model, but it took us years to develop that model. We currently provide a holistic model of care, including pastoral care, behavioral health, primary care, functional medicine, addiction and recovery care, and care for chronic illnesses. We're the only federally qualified health center that has incorporated HIV and hepatitis C care within our primary care model in Kentucky. I didn't always understand the power of nutrition and mindset in healing for years. I practiced traditional healthcare and watched as our prescription pads became our primary tool against chronic disease. I was that provider who would see a child with attention problems and immediately reach for medication options. I believed in our system because that's how I was trained. But something wasn't working. Despite our medications, our community wasn't getting healthier. My wake-up call came through a close friend and colleague, a pharmacist whose young son was diagnosed with severe autism. When traditional approaches offered little hope, he refused to accept that limitation. His journey into nutrition research and evidence-based supplementation opened my eyes to what was possible. Kentucky ranks 45th overall in health outcomes nationally. 38% of our children take at least one prescription medication. I want to repeat that. 38% of our children take at least one prescription medication. Medicaid spends approximately $3,800 per child annually on pharmaceutical interventions, yet we spend less than $200 per child on nutritional education and prevention. Studies show nutritional deficiencies cost our state an estimated $4.2 billion annually in increased healthcare costs, reduced academic performance, and lost productivity. Kentucky's child obesity rate is 4% higher than the national average. We also exceed the national average in key vitamin deficiencies. Our spending on prevention and nutrition medicine is $80 less than the national average per child. Many children today are being treated for symptoms of deficiency, not disease. Low vitamin D, omega-3 fatty acids, or vitamin B12 deficiencies masquerade as fatigue, anxiety, and attention problems. Yet instead of treating these underlying nutritional issues, our system rewards prescriptions that layer side effects on top of symptoms. Our current approach is creating a generation of overprescribed, undernourished children. The problem isn't just medical, it's structural, financial, and moral. Here's what I've discovered after a decade of integrative health practice. True healthcare begins before illness, not after. The body has remarkable capacity to heal itself when given the proper nutrients and environment. This isn't alternative medicine, it's foundational biology. The most powerful prescription we can write isn't a prescription pad, it's a grocery list. When we address nutritional deficiencies first, we often eliminate the need for more invasive interventions later. Here's a basic framework that we've developed to change our approach to healthcare. The nutritional foundation, addressing deficiencies before medications. The environmental protection, reducing harmful chemical exposures. Lifestyle medicine, managing stress and promoting activity, and the appropriate care, preventing over-medicalization through proper diagnosis. Some of you got a full guide. If you don't, you can just email me, and I'll be glad to send you all the research into our model. But let me tell you a little bit more about Jonathan, the son of the pharmacist's colleague. When diagnosed with severe autism at age 4, Jonathan was nonverbal, withdrawn, and struggling with self-regulation. His parents were told to prepare for a lifetime of intensive support. As a pharmacist, Jonathan's father understood medications, and he knew the limitations and consequences and felt there had to be more. His research led him to examine the role of nutrition, particularly compounds like sulforaphane, from cruciferous vegetables, big names, like broccoli, cabbage, Brussels sprouts, essential nutrients like vitamin D, omega-3 fatty acids. Through careful dietary medication, specific supplementation with nutrients like those shown in this book, The Resilient Brain, which was actually written by him. An unwavering persistence, something remarkable happened to Jonathan. Once trapped in his own world, he began to emerge. Today, he's in high school. He's thriving in mainstream school. He's earning high marks. He's playing sports with his peers. That wasn't transformational magic. It was biology in balance. It was the power of nutrition, targeted supplementation, and persistence working together. The most powerful medicine isn't always medicine at all. It's giving the body what it needs to heal itself. So for sake of time, I'm just going to review one pillar of the transformational health model. Again, the most powerful medicine often isn't medicine at all. It's giving the body what it needs to heal itself. With this understanding, it led us to develop what we call the deficiency-first diagnostic framework. Number one is we assess, test for nutritional deficiencies before prescribing symptom-masking medications. We address, we prescribe specific nutrients, dietary interventions based on the deficiency findings. We give the body time to respond and to heal with the proper nutrients, usually taking 3 to 6 months, and then adjust. Only then do we consider pharmaceutical intervention is needed. This framework has transformed our clinic outcomes by ensuring we're treating the root causes, not just symptoms. Here's what implementing this approach looks like in practice. Test vitamin D, iron, B12, and essential fatty acid levels before prescribing medications. For behavior and attention issues. Prescribe specific food plans and supplements to address deficiencies, and then document improvements in symptoms as nutritional status improves, and then collaborate with families on sustainable dietary changes. But this model is tough for struggling families who can't afford targeted supplementation. Getting these supplements covered on insurance is almost impossible. So in our clinic last year, we met Emma, a 7-year-old girl who'd been on 3 different medications for attention problems since age 5. Her mother came to us frustrated. The medications helped somewhat, but Emma still struggled, and the side effects were very concerning. Rather than immediately adjusting her medicines, we did a comprehensive nutritional panel. The results were striking. Severe vitamin D deficiency, suboptimal B12, and omega-3 fatty acid imbalances. We developed a comprehensive nutrition plan, including specific supplementation, like the O's outline and brain research. Within 3 months, Emma's teachers noticed significant improvement in her focus and her behavior. By 6 months, we were able to reduce her medications in half. Today, she maintains her progress with nutrition and targeted supplementation alone. Appropriate care means treating the child, not just managing the diagnosis. This also includes providing psychological support for the child and the family, supporting mental and emotional well-being. This integrative approach ensures that we're not missing critical factors that influence health and behavior. Implementing this framework requires comprehensive initial assessments, including nutritional assessments, provider education on recognizing symptoms of deficiency, and then insurance coverage for preventative interventions, parent education on nutrition's role in child development. The MAHA strategy gives Kentucky a powerful opportunity to lead the nation in healthcare transformation. We're calling for practical reforms that align with this strategy. Community-level transformation grants, funding rural demonstration projects that integrate nutrition counseling, lifestyle medicine, and coverage for clinically prescribed supplements. Medicaid partnerships, pilot coverage for essential children's supplements when prescribed by a licensed clinician, academic collaborations, and then private sector integration. This is not just a healthcare issue, it's a moral one. We have the science, we have the strategy, we have the faith. What we need is the will to act. So your work as legislators are just profound. You stand at a critical junction when policy meets people's lives. The decisions you make about healthcare coverage, about what constitutes as medically necessary treatment, about prevention versus intervention. These choices will echo through generations of Kentucky families. Kentucky can be the first state to fully move from illness to healthcare, a state where every child's nutrition is covered, every clinic practices prevention, and every family thrives in body, mind, and spirit. So together, let's make Kentucky a beacon of true healthcare transformation, because healthcare begins with healing, and that lasts a lifetime. Thank you.
Thank you so much for your testimony. We do have some questions from our members. First, from Senator Funky Fromeyer.
Wow, thank you for letting me go first,
I know.
Mr. Chairman. Thank you, Kim. Thank you for coming all this way to share these stories with us. Incredibly impactful. You gave me chills twice as you were sharing. In the process of assessing the deficiencies, what are the costs of those tests typically that you would run for the vitamin D, the omega, and such?
Actually, the costs are very low, but most insurance plans do cover those tests.
Okay.
So it's not an additional cost, and we're screening for those currently. I think the big additional cost is lack of coverage for supplements.
Okay, great. And just a follow-up to that?
Sure.
Okay.
Quick.
So on the dietetics side or the nutrition side, do you have registered dietitians or certified nutritionists that might be offering some of that information?
No, we don't. Many of our providers are trained in Dr. Daniel Amen's Brain Health University program. So we have a lot of brain health nutrition materials and things like that for access. So we train everybody with that program, our behavioral health providers, our social workers, as well as our primary care providers. So it gives them lots of resources for the patients.
Great, thank you.
Representative Moore.
Thank you, Mr. Chairman. Thank you all for the presentation today. I love the idea of attacking the root cause and not just the symptoms of illness and lack of wellness. I wanted to get your take on when you are working on this holistic method of nutrition and supplementation and lifestyle, these factors, do you think that bears out to be lower cost on the patients themselves over the long run, and also probably then lower cost to the taxpayers as well who are helping pay for that?
Yeah, lower cost to the taxpayers, but initially, supplements aren't covered by a lot of plans, so it is more expensive for them initially. And so talking somebody into that's dealing with food insecurities, that you need to buy these vitamins for your child or even themselves is difficult sometimes.
Thank you.
Representative Proctor.
Thank you, Mr. Chair. Thank you so much for your presentation. I'm excited that we're looking at food as medicine. My question is, what's the compliance rate with making dietary changes or using the supplements?
I think you have to do a global approach with a patient and the families. So I think the great thing is to start with supplements. Behavior changes as far as integrating different foods, that takes longer, and behavior modification. So working with counselors and even health coaches within our system helps to make those changes over long term. So if we can really manage those deficiencies that we see immediately with vitamins, that's great. And then really working on behavior modification. And then families, how do you integrate these other foods into your diet? That's a lot harder and takes a lot more time, education, and coaching.
So do you have kind of what the compliance is with all of that, your success rate for that?
That's a good question. No, we don't have compliance data or success rate, but that's definitely something we can definitely look to find the data on that. Yeah.
Just as a reminder to our members, we have 3 more questions, and we're going to cut it off after that. So, Senator Douglas.
Thank you, Mr. Chairman. Thank you all so very much for your presentations here today. I know that we talked about the structural, financial, moral, and even some of the financial, financial problems, but we all know that our eating disorders or our eating patterns are established as children. And a couple things here. We don't talk a lot of times about the fact that drugs are started because the caregivers and patient noncompliance. And so you'll see this task force look at this from many different angles. But one of the things I wanted to add is I wanted to mention that my pediatrician and my family practice friends often give upfront nutritional information. I know that because I've been in their office. I've known them for years. They also give those guidelines. Would you agree that most of the medications are given really to prevent some of the long-term damage that can occur as a result of noncompliance of the patients?
I think sometimes when we do have nutritional information that we give, but when we do a lab panel where we're actually showing the numbers on the severe deficiencies, I think that's more of a wake-up call to parents. And, when you're seeing the numbers, wow. I think that brings compliance a lot stronger. If now they have evidence, and then they know, we're giving them something proactive to do. But I think seeing the numbers is really powerful for them versus, you got to change your dietary habits for your kids. But when I'm showing them that I can't even detect fatty acid levels on your child, or your vitamin D level is 5, and that this is what it's impacting the brain, I think that's hugely powerful, and that brings about a lot more change.
Thank you very much. Thank you, Mr. Chairman.
Representative Duvall.
Thank you, Chair. And thank you for your presentation today. I would love for Kentucky to take the lead on prevention. This is an area I think we could excel at. The reality is that we're either going to spend a lot of money now on prevention, or we're going to spend an enormous amount of money later to fix all the chronic illnesses and diseases that we're seeing. And so I'm excited about diving into that and seeing what we can do. When you started your presentation, you said that you had some studies that show that nutritional deficiencies cost our state an estimated $4.2 billion. If you don't mind, could you forward the sources for that? And
do you have a folder?
I do, yeah. Is it in part of the packet?
I think it's probably in the
All right,
packet,
wonderful.
yes,
Oh,
yes.
good. Okay, thank you. I just want to make sure that we had those.
Yes, absolutely.
Yes, but thank you. Appreciate it.
Sure, absolutely.
Senator Wheeler.
Thank you, Mr. Chair. That is a very disturbing statistic that 39% of kids in Kentucky are on some type of medication. I mean, do you know, does any of that relate back to the drug issues, drug problems, these kids being born addicted to narcotics and having some subsequent issues with that? Or is this even healthy children that subsequently find themselves in this situation? I mean, do you have any breakdown on that?
I don't have a breakdown, but I definitely have a passion about it. I was just at the opioid abatement conference, and they were talking about different modalities and presentations for how to get kids not to use drugs, right? And I'm thinking, well, we got to start young. We're giving them drugs. 38% of them are giving drugs for behavioral or, we're focusing on them. And then as teenagers, we're saying don't use drugs and don't take drugs. So I really think, we've got to flip that narrative. We're given double messages, and most of that comes for our lower socioeconomic kids. You get kids in foster care, and they're on a numerous amount of medications instead of addressing how they can deal with some of the trauma in their lives and malnutrition. We're not dealing with those things. We're just giving them a lot of medications. And so you see those kids later on, okay, we're giving you lots of medications here to sleep and all this stuff. But then as teenagers, we're going to ask you not to use drugs. You're indoctrinated into that take a pill for program. So we got to switch the narrative.
Thank you, Mr. Chair.
Thank you so much. We appreciate your testimony very much. Thank you.
Thank you.
All right. Up next on our agenda is the KMA, Kentucky Medical Association STEPS campaign. Dr. Sean Jones, if you would, please introduce yourself. I've already stated your name, but state it again, if you would. Make sure that your microphone is on, and you may proceed.
Thank you. Before I begin, I'd just like to say thank you to Chair Lockett and Chair Fromeyer, as well as the other members of the task force, for the opportunity to be here. I am Sean Jones. I'm a board-certified otolaryngologist from Paducah, and I'm president of the Kentucky Foundation for Medical Care, which is the charitable arm of the Kentucky Medical Association. In addition, last year, my wife, Dr. Evelyn Montgomery Jones, a dermatologist, served as the spokesperson for KMA and KFMC's latest public health effort, Small Steps, Big Impact. There should be a handout in your folder regarding that program. Each year, the KMA partners with the Foundation for Medical Care to tackle a public health issue we feel is of importance in our state. In the last few years, we've made topics such as lung health our priority and have reached millions of Kentuckians through advertising, op-eds, media appearances, and educational events. Our lung health campaign, for instance, helped Kentucky become a national leader in lung health screening, jumping our screening rates to number 2 in the nation. As we look to develop our most recent campaign, we came across a study by the United Health Foundation called the America's Health Rankings, an annual state-by-state report widely recognized for providing a comprehensive look at the overall health of each state in the country. The report uses more than 80 health measures drawn from over 20 data sources, and what we saw in the report was sobering. Kentucky was ranked 41st overall out of the 50 states, and we had many challenging areas to improve in. As a physician, this did not surprise me, but it saddened me. Patients facing multiple overlapping conditions. They were both obese, they needed health screenings, but they were also diabetic, tobacco users, and there had to be a way that we could address these topics without making our patients feel overwhelmed or alone. That's how the Small Steps, Big Impact campaign was born. We asked Kentuckians to do exactly that, to make small, manageable changes over time that can add up to big improvements in their overall health. Making better choices, such as choosing grilled chicken over fried chicken or beef, scheduling a mammogram when they're eligible, going for a walk after meals, or getting just 30 more minutes of sleep a night. And Kentucky physicians would be walking beside them every step of the way, building trust at a time when many are skeptical about our healthcare system. STEPS is an acronym for screenings, tobacco use, exercise, and nutrition, physician visits, and stress, which are all areas we ranked poorly on in that America's Health Rankings report. Since launching in 2025, January this year, we've run social media, radio, and print campaigns that have generated over 1 million impressions statewide. Along with educational offerings for our providers, with additional campaigns currently underway across Kentucky. While physicians are well trained on wellness issues, we've sponsored additional training through supplemental CME that ensures physicians have the tools they need to have what we think are very important conversations with their patients. Our topics so far have focused on colon cancer screening and prevention, exercise and nutrition, behavior modification, and suicide prevention. In September, we sponsored a 1-hour KET forum, The Wellness Shift, highlighting Kentuckians who improved their health through small lifestyle changes like those in the Walk a Doc program, or Walk with a Doc program, a national organization that has physicians lead community walks to encourage exercise and connection. I think the success of our campaign is a direct result of the physicians that we've had leading the way. While the campaign's officially led by the KMA president, every member has access to these resources. And in addition, we have more than a dozen physician ambassadors from across the state who've appeared in public service announcements, authored op-eds, and been interviewed by media outlets serving on educational panels. Through this campaign, we've taken the tremendous knowledge our members possess and are speaking directly to the public with encouraging, actionable, and manageable steps. Things that all Kentuckians not only can do now, but can continue to do and make part of their daily lives and routines. Our KMA has seen firsthand what these types of changes can do and what the impact is, and we're echoing the same message together, and we're excited to continue this effort in 2026. Instead of ineffective mandates, we're empowering our physicians to have these important conversations with their patients and provide them with the tools that they need to help Kentuckians make positive steps. We're excited to welcome another class of our award-winning Kentucky Physician Leadership Institute this summer, where budding leaders learn more about public health and advocacy. Finally, since insurers will be speaking today, it's worth mentioning there is a role for physicians, healthcare providers, the Department for Medicaid Services, and insurers to come together. For example, collaborating perhaps to promote proper nutrition and healthier lifestyles by integrating new questions about diet, exercise, and wellness into the social determinants of health forms already used in physician practices and by DMs. These forms currently identify barriers such as transportation and housing, and if not already being used this way, could be expanded to include nutrition and activity questions. And this data that is aggregated could be used and shared by insurers to help identify effective community-based strategies, and in turn, targeted financial incentives could be offered to patients to encourage participation and measurable lifestyle improvements. There are some things that are very easy to identify that would have an enormous impact on public health in Kentucky, but they're politically difficult. Kentucky is number one in lung cancer rates and lung cancer deaths, and we're number two in smoking rates. We've already seen what the smoking rate is in children, and yet we do not have a statewide indoor smoke-free policy that we know reduces smoking rates in children. We don't have a motorcycle helmet law for adults. We don't have opt-out policies for CDC recommended and U.S. Preventative Healthcare Task Force recommended vaccines. We don't have healthier, whole food, predominantly plant-based breakfast and lunches served in our schools, which are free of added sugar, processed foods, caffeine, as well as free of milk and dairy. All these are actionable steps that can make a difference in the public health of every Kentuckian. I want to thank you for allowing us to share information regarding our Small Steps, Big Impact campaign, and I'm happy to answer any questions.
Thank you so much. We do have a question from Senator Fromeyer.
Thank you so much, Dr. Jones. Really appreciate you being here today.
Thank you.
In the process of your continuing education, what sort of continuing education is expected of physicians around nutrition? And in the example, the presentation just prior talked about some tests that might be done in the process of visiting with the patient, and then perhaps compelling their behavior by showing them some astounding results of their blood work on vitamin D and such. But what sort of continuing education are you expected to receive in nutrition?
So I'm a member of the American College of Lifestyle Medicine, so I'm very familiar with the principles and practices, and I employ those daily in my work. I think it is interesting and certainly impressive, some of the results that were shared. I think if you have children on a whole food, plant-based, predominantly plant-based diet, the vast majority of children who do not have genetic abnormalities or other deficiencies, who are what we might consider normal kids, will not have those deficiencies. So if we can get them to a whole food, plant-based, predominantly plant-based diet, they won't have low fatty acids. They won't have some of those low measurable issues. But certainly to turn it around, it's not unreasonable to start with supplementation and then convert the diet. But making those small steps can be as impactful as any therapeutic intervention we might consider. I do agree that the food and dietary recommendations are probably more important than medication in many instances. And certainly sleep and exercise and avoiding toxic substances goes with that.
So in the food and dietary recommendations, is there a standard that is being I'm a certified financial planner, so each year I have to go through licensure and acknowledge that I have met the 36 hours of continuing education. So kind of going back to my question, what sort of continuing education is required for professional licensure in order to keep your licenses in good order?
So the Kentucky Board of Medical Licensure requires we take, I think, 40 a year. I always go so far over, I don't even honestly remember what the minimum is. But it's difficult to specify specifically for nutritional advice, for example, because a radiologist has very little use for nutritional guidance in patients when he's reading an x-ray, for example. And so most specialists particularly will want to be in their area of expertise. And for instance, when I take nutritional or dietary CME guidance, I do it through the American Academy of Otolaryngology because it's more specifically relatable to my specialty and doesn't, go into other things that might not be applicable to me. Pathologists and other types of physicians wouldn't have as much need for the same dietary guidelines and recommendations that a family physician might have, for example. So I think those specific recommendations are pretty vague for a reason.
Thank you.
Senator Chambers Armstrong.
Thank you, Mr. Chair, and thank you, Dr. Jones, for being here today. I'm curious, you were talking about whole foods, plant-based diet for kids. I have a 4-year-old and a 6-year-old, so I buy a lot of food, and it seems like I try to give them lots of fruits and vegetables. And every time I go to the grocery store, which is at least once a week, it's $100, right? It's sometimes more if you're getting those blackberries and raspberries and bananas. And I'm just curious, when either you are talking to patients or when you're talking to other people, other doctors about talking to patients, how often do you hear pushback from patients about the cost of, how am I going to afford this? Yeah, sure, I'd love to buy more whole foods and more produce, but do you know where I can get it at a price I can afford? Do you have those conversations with patients?
I do have those conversations, and I would say I would avoid raspberries. They're my favorite, but they spoil really quickly and they're very expensive. So I think you have to be, wise about that and look, that's part of the social determinants we talk about is, if I've got a patient who I know is a Medicaid patient, for example, then I'll talk to them differently about what their options are. But I think eating an ultra-processed diet is not only very unhealthy, but it also tends to be more expensive in the long run, just You know, when you look at frozen pizzas and Lunchables and all those things, I can go to the grocery store 4 or 5 times in a 2-week period and buy fresh fruits and vegetables and eat much cheaper than someone who's eating out of the frozen food aisle.
Thank you for the answer, and I'll remember that tip about the raspberries.
I love them, but
Thank you so much. We appreciate your testimony, Dr. Jones. Thank you. All right, moving on, getting into our health insurance and preventative health initiatives. I'm going to go a little bit out of order than what is listed here and call first from Anthem and Elevance. Hope, if you would come to the table and introduce yourself. I'm calling Hope out of order. Anthem is not an MCO, and so I'm going to let her go first and talk about Anthem projects, so forth. So please introduce yourself, and you may proceed.
Okay, can you hear me okay? All right, Hope McLaughlin, Senior Director of Government Relations for Elevance Health, Anthem Blue Cross and Blue Shield in Kentucky. Really appreciate the opportunity, Co-Chair Lockett, Co-Chair Funky Fromeyer, to be here today. We've had a lot of conversations about these topics and appreciate your willingness to hear from me about how we work with our customers through our well-being solutions and other programs to improve the health of our members. To give you a little bit of background on Anthem Blue Cross and Blue Shield, I have to say this anytime I'm in front of somebody. We have been serving the Commonwealth for over 87 years. Not a lot of people realize that, and that is something that we are very proud of. We employ over 1,500 Kentuckians across the Commonwealth, and we serve customers, the businesses that we provide benefits to, and policyholders in every county of the Commonwealth. Our primary goal is to deliver high quality, affordable care to our customers and our members, and currently we're operating in the commercial and Medicare lines of business in Kentucky. Almost everything that I'm going to discuss with you today is going to be focused on what we offer to our commercial customers, primarily in the fully insured space, but these options are available to our self-insured customers if they choose to take advantage of them as well. I also provided some handouts on the state employees health plan to you on what is offered in this space, some well-being solutions types of things, and those services that you can avail yourselves of on your health plan as well. So our focus at Anthem is really the whole health experience. We've talked about it here today. We pay more in America with poorer outcomes than other countries. And so how do we address this, and what is the role of the insurer in this space? So for us, we offer extra support and programming for our members who have chronic conditions, whether it's a new illness or injury, or diabetes or cancer, something more long-term. We help them coordinate their care because the healthcare ecosystem can be challenging to anybody trying to manage through it. We have nurses and wellness experts that are doing outreach to members. We provide digital alerts with reminders for members to fill their prescriptions and attend their appointments. These things will provide results for improved well-being and for better outcomes and healthcare savings, which provides our customers, those businesses, a return on their investment for offering these programs to their employees. And so what's on the screen now, this is an example of a well-being solutions option that we might offer to a fully insured member. These areas go across physical health, behavioral health, financial, and social health. Again, getting at that whole health aspect that I mentioned. And these are really targeted toward ensuring that members have access to health and wellness offerings to improve their well-being. You can see in this example, the preventative services are covered at 100% with zero member copay. We've talked a little bit about how important that is today and other times as well. This includes support for family building, maternity care, fitness and nutrition tracking, which we've talked about today as well, SUD engagement options, on-demand options for anxiety and depression for members, and also the ability to earn back dollars for receiving this care. And I also want to mention we also have some options for access to 24/7 community resources. This, what's on the screen now, is an example of a member engagement package, which allows members to earn dollars back for getting that preventative care. In this example, members can earn up to $200 by engaging in programs designed to meet their specific needs. You can see there, as an example, an annual wellness exam, they can earn $25, tobacco cessation and coaching at $25. You can track your steps and earn up to $60. This is an example of what we offered in 2025, and we're going to have some additional offerings in 2026 because we always like to change things to the needs of our customers and our members. And so I mentioned the whole health approach a moment ago. So by bringing together a full spectrum of well-being solutions through integrated care and coordinating all of this under one roof, all the needs of a member are met, and they receive what they need to be healthy in one spot. And what we have found through our research, as you can see there on the screen, members can actually save money through this integrated approach. When they have everything under one roof, it makes it easier for them, and it also helps them save dollars. We also found that this improves health outcomes. We found that ER utilization decreased by 58% for those that were participating in our cancer care program. And employees that were participating in our wellness programs, after 20 weeks, lost 3% of their initial body weight, and almost 24% lost at least 5% of their body weight. So these are having a real impact on those employees. So if you've had a conversation with me in the last couple of years, and I think all of you have heard me talk about the Sydney Health app. People actually tease me now that I've become this sort of unofficial ambassador for the app, because I really do love the things that it offers to our members. I think it's a really powerful resource for them. It's truly designed to be our digital front door for them. Through the app, you can see all the things that you can do on the app here. But to mention a few of those things, you can track toward your deductible, which is really important in knowing where you are in the year. You can also find your in-network providers. You can price out the care you're going to receive based on your health plan and the providers that you are going to see. And you can even track the status of your prior authorization requests from beginning to finish. And I like to call that our pizza tracker, because that's what it looks like when it's going through the process. So this is not just about calling customer service and checking a claim. It's really about being able to use your smartphone to coordinate all of your care and even access care directly through your phone if you need to. You can see we have a strong adoption rate in Kentucky. Over 68% of households are using the app, and they're not just downloading it and leaving it there. 85% of those members are staying engaged. They're finding care. They're utilizing those health and wellness programs that we've been talking about, and they're also tracking their claims. So we've also talked about food as medicine. Food is medicine here today, and at Anthem, we're big believers that nutritious food can improve health outcomes and decrease the likelihood of many conditions long term. There are a variety of different options based on the population that you're working with that you can utilize. In the commercial market, we are really primarily focused on those coaching and wellness programs and integrating that nutrition coaching and helping members make good choices, because those members are better resourced and they don't necessarily need those public nutrition security programs. We have had several conversations with Commissioner Schell about the programs that we offer. We know this isn't a priority for him, and we've shared our research with him, which I have linked on this website for you. We have a food as medicine report that actually identifies our programs across the country that we have employed in a variety of plans across the country and the impact that that has. And I think that he's found that helpful as well. And so we'll definitely continue those conversations with him. I also want to mention that we have many partnerships with Dare to Care and Feeding America and things, like offering fresh produce to people that need it and prescription boxes for people as well. So part of encouraging members to take care of themselves and providing incentives to get that care is about maintaining affordability, because being able to pay for the care is a critical part of the conversation. The Smart Shopper program encourages members to get that care and do it with high quality, cost effective providers. You can see there that in this example, the cost of a colonoscopy can vary greatly by provider. And so when a member chooses a more cost-effective provider, they will receive a reward in the mail after the claim is paid. You can see examples of procedures and corresponding rewards on the right. Do want to mention this is also an option with the State Employees Health Plan. And you ask about innovative payment options and solutions. And so, value-based care is really about prioritizing quality over volume. These arrangements that include risk sharing with providers and allow providers to be rewarded for improving health outcomes have been effective across the country. And that's what the numbers across the bottom represent. These are not just Kentucky statistics, which is why they include all those different lines of business. This is what we have seen from 2024 about the providers that are participating in these programs, the health metrics that are tracked for those. You can see how much they outperform the providers that are not participating in those programs. And we utilize these programs in Kentucky as well, primarily in the primary care space in Kentucky. And we're seeing outcomes like this similar in Kentucky as well. We're seeing more well child visits happen in Kentucky, more breast cancer screenings, and fewer inpatient admissions thanks to those providers that are participating in those programs. I am glad to answer any questions you have. That was fast and furious, but happy to talk about anything else.
Thank you for the quick presentation, Hope, and thankfully we are not talking about prior authorization today. That's a very good thing. So I'm actually going to start us off with a couple of questions here. First of all, going back to the engagement package 200 slide that you had.
Yeah.
I know you talked about the participation rate for the Sydney Health app. Do you have a participation rate in terms of like the engagement package, preventative care, how many people are earning those dollars and so forth?
So that's a great question. So we offer this package within our fully insured customers. They get this package as part of a fully insured plan. For self-insured customers, those customers buy up to that plan because it's their health plan. They decide what they're going to offer, what the benefits are going to be, what the wellness options are going to be, and that sort of thing. And so I don't know that we have any data for the employers that are offering it, because not every self-insured employer decides to offer this package or any package. Some of them do, but not all of them do. And so I can see if we have any information on that and follow up, but I don't have anything with me today.
Okay. And second, can you speak to a little bit about a topic that I'm just beginning to learn about for various reasons because of my wife, but hormone therapy in terms of coverage from insurance companies, what it does and does not cover, and in terms of kind of the root cause of that, getting more towards preventative without having to go on medicines and so forth.
Sure.
When that is utilized, it's a lot less expensive. But I've learned that a lot of insurance companies do not cover that. Can you speak to that?
So actually, I don't have a depth of knowledge about that, but I'm happy to ask the questions and come back to you on that particular piece. I will say that in this sort of same well-being area, I do know that we've partnered with a group called Maven that offers benefits to women who are approaching perimenopause and menopause. It's kind of a coaching program helping them to go through the process. I got the email myself as a member, and I was like, oh, well, this is interesting and a good option for women to have. So there are options like that out there. I don't know the details about what we cover specifically in that area, but I'm happy to get back to you.
That'd be great. Thank you.
Yep.
Representative Proctor.
Thank you, Mr. Chair. Thank you for your presentation. I really like the part you have on here about the smart shopper and being able to compare locations for different services. Now, you can do that in Lexington. You can do that in Louisville. And you can even do that in Bowling Green with a population of 80,000 that has 3 different hospitals. However, in Boone County, where I've got 143,000 people just in Boone County, we don't have that option to look at where you'd have different providers, because we only have one that covers 17 different counties of Northern Kentucky and Eastern Indiana. So where do those people go, and what are their options to be able to shop for these services at a different location that could perhaps save them significant amounts of money?
So I don't know what I know what your question is in reference to, and I don't know that I want to wade into that. There are options for members there. I hope that you do utilize the Sydney Health app and see if there are other options that are available to you. And I don't know what Smart Shopper options are available in those counties specifically, but I'm happy to look into that more and get back to you.
So are there not any, or do we have to go across to Ohio?
I don't know what the options are. I think that typically, the more affordable options are typically closer to home. If going across the state line would be different, but I don't know what the options are specifically for those counties.
Thank you. Thank you, Mr. Chair.
Any other questions? No more questions. I don't see any more. Okay. Senator Fromeyer.
I'm kind of passionate about this whole subject, so hard for me to resist. So I appreciate the information that you're sharing, and it was interesting going to the reward employees for cost-effective choices slide. We, of course, received the presentation about smoking cessation and such.
Yeah.
And then I see sample procedures and rewards, but I don't necessarily see anything about how to promote lung health. I also don't see anything about like a blood glucose monitor, by example. It would be the next page, the reward employees for cost-effective choices. And I guess this is sort of trying to get upstream of the issue. If a young person maybe even receives a pulse oximeter and they get some idea that they're killing themselves with the consumption of the flavored vapes and such, but they can actually see it. They can visually see it, and it becomes some sort of a family tool even, so they can better understand. That's one question / example, and the other question / example goes to a blood glucose monitor. So if you're consuming ultra-processed foods, or as Dr. Jones was sharing, some more nutritionally whole type of food diet, you can see that. You can see those results in a blood glucose monitor. What sort of tools are being offered to patients so that they can maybe get ahead of their health or see the results of the choices that they're making as we reflect on patient compliance, how to build compliance with knowledge?
So the on the page that shows the rewards that members can earn, there are rewards for tobacco cessation coaching. I haven't been through one of those programs myself, and I don't know the details of it, but members are incentivized not to smoke and to stop smoking. In terms of the nutrition coaching, I don't know that our coaching programs offer glucose monitors. Certainly if somebody is diabetic, certainly that would be something that would be, offered to them. But I can say I have been taking advantage of the benefits that are offered to me, and I have been meeting with the nutritionist as part of the coverage. And she, talks to me about how to make decisions. And it's just very different when you're talking to a professional and keeping those things front of mind. Like I find myself making different choices just because I'm meeting with this woman once a month virtually. And so it's really about that type of resource for the members more so than additional healthcare things that they might not have that they've been diagnosed with, like a glucose monitor or something like that. Certainly if someone needs it, that's part of their healthcare for sure.
And just confirming with what you just said then Anthem is actually offering nutritional coaching to a person that's asking for it.
So it is offered in those wellness benefits. If an employer decides to offer those wellness benefits to their employees, it's included as part of our fully insured package that I showed on the screen. And for those employers, self-insured employers that are making the decision to offer those benefits, then for some of those packages, it is part of that package as well.
But for mostly, it's not. Nutrition coaching isn't covered unless you're pre-diabetic or unless Are there specific reasons that it is offered then?
So it's we target members in those wellness programs that are identified as needing it for some reason, or they're seeking it out for some reason. And that's part of the wellness package. It's not covered as a benefit. It's different in a wellness package than what it is as a benefit. Does that make sense?
It does, except for I see that we're 40th in obesity. So I'm somehow struggling to understand how absolutely every person that is asking for this help, it wouldn't be covered. So just a signal out there to the universe.
We are going to move on. Thank you,
Thank
Hope.
you.
I certainly appreciate your testimony.
Thank you.
I'm going to call now WellCare, if you would. Darren, go ahead and come to the table. And again, introduce yourself. And I believe you also have a presentation, PowerPoint.
Yes.
Introduce yourself, and you may proceed.
Well, hello. Thank you to the chairman and the committee task force for inviting me here today to share some of our story with you. Dr. Jones, I want to thank you for kind of teeing up some of my conversation today, talking about social determinants in health and how class we eat. But I did answer your question. I'm Darren Levitz. I'm the Senior Director of Health Equity and Member Experience here at WellCare of Kentucky. When I came on, I took a look at our social determinants in health equity programs, and I knew I wanted to change a couple of things. You know, when we look at social determinants, it's the number one predictor. The tools we use with social determinants, are the number one predictor for longevity in this country. You can guess someone's longevity in this country by their zip code more accurately than any other factor. It's not heart disease, it's not cancer, it's not COVID. It is their zip code, is where they live, is the number one predictor that we have in this entire country and in the Commonwealth on how long someone will live. And that's because of social determinants. Do they have access to the care they need? Do they lack resources to heat their homes, to feed their families, to have stable housing, and on and on and on? So I asked my team, and this is a question that's probably very salient today, was who thinks that we should do a food insecurity program? You know, if I asked a room not only of just my team of 13, but everybody here and the whole stadium, I mean, who's against food insecurity? That's like saying who's against motherhood or who's against basketball season starting tonight. These are givens, okay? But what we decide to start doing different is really look at the uniqueness of our state. We know that metropolitan areas such as Louisville are going to be different than places like Centertown. There's inherent differences. So how are we going to look at those differences? Well, we're going to let the data drive our decisions. And what we use are publicly available sources such as the SVI, the Social Vulnerability Index, and some proprietary data that we have. And we analyze for each of Kentucky's 120 counties what needs are the greatest, what are the most salient in each one of those counties. And this is a tool.
So, Darren, I'm going to jump in here.
Yes, sir.
Sorry, just to remind you, you've got about 7 minutes, so
Okay.
just kind of keep that in mind as you're going.
Will do. Thank you so
you.
much. So looking at this really quickly, you can see in here, even with here in Western Kentucky, how varied the needs are. The number one need in Fulton County is housing or crime and violence, but you may look in another area where the greatest need is access to care in Graves or enrollment in education in Trigg County. So we make sure that the programs that we're doing are the ones that are most needed in that, and we let that drive us. The other thing that we wanted to do is inherently you say, well, if we do a program, it's going to provide good, right? And we feel that in our gut, but we've never really been able to demonstrate that until now. And what we do is when we provide a grant, and these are not just to WellCare members, these are to anybody in the community that grabs these resources through a community-based organization partner we provide the grants to. And then we look at our own members, because we have data on that, to see what are the results prior to that intervention and after, and then we quantify that. And I won't read through all these, but I'm going to run through a couple real quick. With Hotel Inc., where we provided just $6,000 to help with a food pantry and financial assistance and housing, you see here that we have quantifiable metrics that show there was a 67% reduction in inpatient stays, a 100% reduction in readmissions, a reduction in ER visits, and a reduction in pharmacy and medical cost. For another one, we gave $20,000 in Ashland, Kentucky for services that included housing referrals and utility assistance. And you see here, quantifiably, we can show a true ROI on these programs. I've heard questions throughout the day that say, yeah, but show me the proof. Well, we can. These are the real numbers that show that these SDOH programs do have positive health benefits. At Welcome House, which I'm going to talk a little bit more later, this is a housing program that we worked with, and you see, again, real numbers that are reducing inpatient visits, ER visits, and medical costs. This benefits everybody. This benefits the member, it benefits the plan, and it benefits the state because we are driving down cost by doing those measures on the front end. I've heard a lot of conversation today about how do we get in front of the problems. This is how we do it. So these are examples of contracts that we wrote last year, our last full year, totaling over $200,000. I'm not going to read through each of these, but you can see we strategically go through county by county and assess where those needs are, what the need needs to be addressed, and then work with those community-based organizations to address those specific needs in that county. We also work with the withholding program that the state has issued, as well as our quality team to make sure that our team is aligned. And we're looking at things such as diabetes, in well visits for kids, in vaccines, and postpartum care, all things that we know have very serious health implications and a lot of preventive work that we can do. And we're making sure that we are tracking and addressing those specific needs that are important to the state, to the plan, and of course, the people that are served by the Medicaid services. We also have community impact councils that we drive across the state. And this is where we bring multiple community-based organizations together and take a leadership role to help align them with the data that we provide and the needs that they're seeing and address specific needs. And this is where our team, which is located throughout the state, you can't do this 8 states away. You can't do this even in the Louisville main office. You have to live in those communities to understand these needs. And we address specific things. One thing I love giving this example is we saw for some reason in Eastern Kentucky that young males kept getting concussions. I'm like, why is that? And the person on my team who lives in Perry County laughs. She goes, I know without looking at any of the data. She goes, these are guys who are on their ATVs saying, look at this, right? They're getting concussions. You have to be in that county to work with that. So these are all committees that we help chair, stand up, and have tangible results. One of the ones that was my most favorite was 2 years ago was in Western Kentucky, where within an 11 county radius, there were 0 daycares. We established, with our help, launching 3 daycares, essentially addressing that daycare desert need. And now kids are hitting developmental milestones and parents are able to work, and we're seeing people get out of the system, becoming self-sufficient because with our help, we've established a daycare. These allow you to read through at your leisure, but you see some of the investments that we have in social determinant and health equity needs. Last year, that totaled about $118,000. We make sure that we are present throughout the state. We are literally in all 120 counties, attending meetings, doing community events, providing resources, and working with them over a number of different targets. One particular target or project that we had last year, we did winter coats, where we provided over $10,000 worth of winter coats in different places throughout the state. That was a wonderful program that was identified as a need. I do want to spend a minute or two before my time is up talking about two specific programs that I'm really excited. These are existing programs that we started with grants at the plan level and have recently been expanded. And the first one is a food as medicine program in Eastern Kentucky. You know, Kentucky ranks 48th in the country in diabetes, and almost half of Kentuckians are either diabetic or pre-diabetic. We are working with Cane's Kitchen and our partners at Mountain Comprehensive Healthcare to do a food as medicine program where a social or community health worker, will do in-home visits delivering meals, because we know, because we have people living there, they lack the transportation, or there are natural barriers that will prevent them from getting the food. So we make regionally appropriate food that they're going to have, but are on a low sugar diet in delivering them. And as they deliver them, they're doing their metrics. They're taking their A1C. We're checking for blood pressure. We're looking for other indicators. We've increased this program from $30,000 to a program that we are going to be launching beginning next year to $500,000. Serving hundreds of people that live in Eastern Kentucky with this program. And we are thrilled to be able to launch that and support with the Centene Foundation, our philanthropic arm of our parent company. And we'll be coming back to you, hopefully, at the end of that 3 years or in the middle, to show you data just like I showed you earlier that is driving down A1C, that is having better health outcomes because we're bringing the care to the people. One other thing I want to say before I wrap up is we're also expanding another current program we're funding at $70,000, and that is a housing project. Now, this isn't just we're going to get people off the street and put them into a temporary housing situation. We're going to take these people. First, we're going to get them with a PCP and address any immediate health needs. And as they graduate past that, then we're going to teach them how to take care of that home. Skills like how do you keep an apartment clean? You know, how do you do basic maintenance? How do you get a grocery list? And then we're going to start showing them life skills. We're going to help them work and find employment. And what we found already in the first year of our program is that 40% of the people before 8 months is up have already signed leases on their own. They have graduated to a permanent housing situation, which we know is going to lead to better health outcomes. This program is going to be invested in for $1.1 million over the next 3 years, working with about 250 to 275 people, not only providing them with housing, but the skills that they need to become self-reliant and hopefully, again, out of the system.
Very good. Thank you so much, Darren. I'm going to kind of cut you off a little bit there. Do we have any quick questions from our members? Representative Moore?
Thank you so much, Mr. Chair. I know we're short on time. I would love to get as much data, and I bet every single person on this panel would. I mean, some of these numbers as far as reduction in ER visits and everything else, you've got confidential and proprietary information written here, but whatever we can have to make sure that we were doing a disservice to Kentucky if we cannot replicate this in ways as much as possible if we're helping people and we're reducing costs this much.
And we are happy to work with you on that. Absolutely.
Thank you.
Yeah.
Thank you, Darren. We appreciate your testimony very much. Thank you so much. I'm going to call Humana to the table and get Jeb and Leslie, if you would, come on up. Come on down. You're the next contestants on Make America Healthy Again. If you would, please introduce yourself, and you may proceed. And keep in mind, too, that brevity is next to godliness. So,
yeah, absolutely. We won't present our full deck, but we'd love to answer any questions you may have. First, thank you, co-chairs, committee members, for the availability for us to speak on our programming. We're excited to share what we think about advancing healthcare in the state, especially around advancing provider payment methodologies and benefits we design for our members. I know a lot of these committee members, committee settings, we talk about bad news. You know, I want to bring some good news too, as we think about healthcare and our providers in the state. If we look at our recent NCQA scores for Humana, we became a 4-star plan. That's the best health plan as we think about NCQA in all the states we have as a segment. As we think about the CAP scores, what do members and patients think about healthcare in the Commonwealth today? A lot of good news. So 5 stars as we think about their rating of their health plans. 5 stars if they think about access to care within this state. 4 stars, you think about timeliness to health care in this state. So members appreciate the services, not only that the MCOs provide them, but that provider community is ensuring that those services can be rendered. If I think about what is core to Humana's strategy, it hasn't changed since we've entered this market. It shouldn't change for any healthcare plan. It's about how do you engage primary care to ensure that coordinated care results in better outcomes. The way we think about that is what we call a path to value. So what our model is, we approach our primary care physicians. More and more, that's a lot of our integrated health systems. We approach them with what that path looks like. First, it looks like quality, and it aligns to how the state contracts the managed care organizations. There's a 2% withhold, and what we do is we take those HEDIS measures and we take those outcomes and we put those in those contracts. And if we're able to execute to what the contracts that have been given to the managed care, we pass those savings on to those providers. But what's key to us and what needs to happen in the Commonwealth is we have to see an advancement. What should happen is quality is the first step. Second step is shared savings, meaning if we perform as a health plan, if the outcomes of those members results in lower healthcare costs, those providers should receive part of those savings. We're seeing that advancement, but what we haven't seen and what we're seeing in other states, and that's a conversation we need to have around policy and around relationships with our providers and advancing our contracting, is full risk contracting. If you go to Illinois, if you go to Ohio, if you go to Florida, both in pediatric and adult Medicaid, you see full risk contracting. That's something we're seeking to achieve in Kentucky, but frankly, we're not there yet. If we look across our value-based contracting strategies, 66% of our members are in a value-based contract, meaning we have a contract with that PCP or that integrated health system that will provide a quality-based payment based on HEDIS. 16% of our members who are in those value-based contracts are in a shared savings arrangement, meaning if that integrated health system is able to achieve a savings from their prior year's claims cost, those savings will be passed upon to that system. And that's a really, I think, a core next step is where we need to see an expansion of, is really a stabilization of our experience in the state and deepening that relationship with a commitment to value-based contracting. I introduced myself without introducing the talent today. Leslie Clements is our population health director. I've had an opportunity to spend some time with quite a few of the committee members here today, but what I want to offer is a commitment to either in Frankfort, in your home district, or within our offices in Louisville. If you want to spend time talking about healthcare policy, if you want to know more about managed care, we would love to be your partner in that, and we will make ourselves available when you're available. So I'm going to pass it to Leslie to share a little bit more about our advancement in contracting and value-based care.
Great. Thanks, Jeb. As Jeb said, I'm Leslie Clements. I direct our population health strategy, lifelong Kentuckian. And I've got a really amazing team of care managers, community health workers, community engagement representatives, and they do a lot of what you see on the slide here. I'm not going to read every word to you. You've got a lot of slides in your deck. You're welcome to check those out and let me know what questions you have. But we really are focused on preventative health care because we know that most of us would prefer to get and stay healthy. And so we've got a patient-centered care management program. And what that means is, yes, we work closely with our members that have chronic conditions, but we're also available for our members who are healthy or want to stay that way. And we do that through a lot of resource navigation. So we help make sure that our members are aware of the resources that we have available, of the benefits that we make available to help them get and stay healthy. We also help them navigate the very complex healthcare system that we have. If someone needs access to transportation because they need to be able to see their primary care physician, we're going to help arrange that for you. You need to know where your closest food pantry is, or maybe you need to know how to use your SNAP dollars at the farmer's market. We're going to help you navigate that too. We also have a workforce development program. So if you're trying to find stable employment, meaningful employment so that you can provide for yourself and your family, we're going to help you with that too. So it's all about those wraparound services that we've heard many people say here today are absolutely critical for people to be able to focus on their health. We, like many of the other MCOs in Kentucky, have several partnerships with community-based organizations, with academic institutions. One that you have a slide in your deck that you can look into is with the Food as Medicine pilot. That's with the University of Kentucky Agricultural Institution, or the School of Agriculture. This is a really cool program for a few reasons. Number one, it helps people access healthy food, especially if they live in a food desert. We've got food deserts all over our Commonwealth. And what we like about this program with UK is that they will deliver food to people's doors that is medically appropriate for what their needs are, that's culturally appropriate for what they like to eat. And so we will be measuring to see how's that affecting people's A1C levels, especially if they are someone who is pre-diabetic or already has diabetes. We want to see how that affects their food insecurity. And we're going to continue to reach back out to those folks to see, were you able to sustain some habits, some positive habits around the food that you choose, the food that you cook, and how you consume that food. We have a lot of value-added benefits, and I won't go over all of them. You'll see a few examples on the right-hand side of your slide. There's another slide in here that does go into all of them, but you'll notice that many of them really are about prevention. So there's information there about that workforce development program that I mentioned before, where we will help people access childcare, transportation, so that they can get to that job. We also make sure that we've got lots of supports for nutrition and physical activity. Someone said earlier that it's really important that we start young. That's something that we've been very intentional about as we've developed our value-added benefits. We've got a new one coming next year that I'm very excited about that is related to youth recreation. We know kids need to get outside. They need to be able to exercise and have a good time and be safe while they're doing it. And so we're providing a benefit that will provide financial assistance to make it easier for families to sign their kids up for sports. We'll pay for that sports physical when it's time for them to go in and have that done. We'll provide resources for kids for tutoring so that they can excel in school. If they're ever admitted to the hospital, then we will send them home with medically tailored meals, whether that's behavioral health hospitalization or physical health hospitalization. All of our members that go home, they get those medically tailored meals because we know that's one of the things that will keep them from readmitting. So there are lots of examples of things that my team of community health workers and our care managers are doing to try to engage our members in their own health. We have lots of community-based partnerships that we know are important as well because we can't do this ourselves. We have a long-time relationship with Volunteers of America. We started a partnership with them in our Kentucky Medicaid plan, the Freedom House Recovery Program, which provides supports for families, keeping them together while they're breaking that cycle of substance use. And it's something that has been so successful that other states that are a part of Humana's Medicaid program are adopting that same model with Volunteers of America. And I've got many, many other examples that I could share with you all of those important partnerships that we've put into place with those kinds of organizations. The last thing, I know we're probably running into time here, but our Go 365 rewards for healthy behaviors, that's another thing that we're really excited about. We do know that incentives do help people. We've got several pilots in place with other technology platforms that have similar programs available so that we can continue to enhance our Go 365 Healthy Rewards program. The last thing I'll leave you with is a story, and that's the slide that Jeb just skipped back over. So I probably have dozens and dozens of these I can pull out for you. I liked this one because this was a family that we worked with. So this was a mother of 3 young children, and we noticed that they needed their wellness visits. And so we proactively reached out to them, and we spoke to this mother, and we learned that she had lost her husband. This is a young widow who was having a really difficult time being able to manage all of the things that her family needed. And so we helped her make those wellness appointments for her kiddos. We made sure that she had the transportation she needed to get them there. We learned that one of her children was really having a tough time with this loss. And so we made sure that that kid had access to behavioral health and access to be able to get to those behavioral health appointments. We made sure that that member knew about all of her benefits, the rewards that she could earn by getting her her children into those wellness visits. She expressed that that was going to help her buy groceries. And we followed up. She made the appointments. She actually attended the appointments, and we continue to stay in touch with her because we know that she'll need that kind of continued support. And that's what really is going to help her and her children continue to stay healthy through their lifetime.
All right, thank you so much. Do we have any questions from members? Representative Proctor, you get one.
Thank you. It'll be brief. I'm just wondering, where did you get all the funding for this? You said you've got partners, but I'm seeing money for haircuts and fitness devices and gears and things like that. Is there a cost shifting from those with regular, commercial Humana insurance to subsidize these, or where does this money come from?
You want me to answer that?
Please.
Thank you, Representative Proctor. It's part of our capitation rate. So these are not funded. As you think about how the state builds up a rate for a health plan, they look at a claims experience, they look at administrative costs, they look at profit. Today in Kentucky, about 92.1% of the dollar we get goes towards provider claims. Around 6% of it goes towards admin, and around 1.1% goes to potential profit. I would say that is one of the highest MLR claims target of any state in the Commonwealth. You have a good value. The way that we pay for these is we take part of our administrative cost that's allocated to us, and we bring it over and we utilize that to pay for these services. The intent of the services is to reduce the claims costs. That's why we have value-added services. It's not just a marketing component of the program. The goal of all of these should be, if I bring this preventative event, they'll ultimately reduce the claims costs. And that's what we believe is happening when we provide them. Thank you.
Thank you so much for your testimony. We certainly appreciate it very, very much.
Thank you, sir. Thank you.
All right. Next up, we have United Healthcare. If you would, Whitney Allen, go ahead and come to the table. If you would introduce yourself, and you may proceed.
Thank you. Good afternoon. Thank you. Good afternoon. My name is Whitney Allen. I'm the Chief Enrollee and Quality Operations Officer for United Healthcare Community Plan of Kentucky. Thank you, chairs, members of the committee, for the opportunity to share United Healthcare Community Plan's work just to improve access to preventive care for communities across our state. Foundationally, we believe that healthcare is inherently local. So we use an approach that recognizes every community is different by leveraging a comprehensive framework. We use to understand and address that there are multiple factors that really influence health care outcomes. We identify challenges using market-specific data and insights, ensuring strategies are really responsive to those unique needs of each community. Our approach integrates feedback from key stakeholders, so members, providers, community partners, to really co-create meaningful solutions. So we set clear, actionable objectives aligned with local priorities, driving accountability and impact across all levels of engagement. So I want to give just a couple examples of some of the work that has been underway. The first one is our mobile mammography. Breast cancer is one of the most treatable cancers when detected early. Rural and underserved areas often lack convenient access to screenings. Kentucky actually ranks 38th in the nation for the percentage of women receiving mammograms, according to America's Health Rankings. So to address this, we launched a mobile mammogram initiative. We partnered with the Kentucky Primary Care Association and over 30 clinics across the state to schedule patients for a mammogram. The unit travels statewide. It's offering no-cost mammograms, and it's in the parking lot of trusted provider offices. Our goal is really to eliminate the transportation and the cost barriers, so ensuring that every woman has the opportunity for early detection. Second program I want to mention is around diabetes and nutrition outreach. Kentucky faces high rates of diabetes and related complications, particularly in low-income and rural populations. So to help combat this, we've introduced a home-delivered meals program through Mom's Meals for members living with diabetes that have an A1C over 8 or more. So the program delivers 14 meals each week for 8 weeks. So it's a total of 112 meals, plus 2 nutrition counseling sessions to help manage diabetes. And early results, we've seen a really good reduction in A1C levels. So it's definitely making an impact. So by combining the clinical screening with that practical nutrition support, we really aim to reduce the long-term burden of chronic disease. Finally, we've taken steps to address the high prevalence of oral cancers in Eastern Kentucky through a $1 million investment with the University of Kentucky. So in addition to more than 1,800 individual screenings, University of Kentucky Dental School also held nearly 200 education sessions with healthcare providers, students, and community-based organizations. They developed 2 accredited continuing education courses for healthcare professionals. These are just a couple examples. We know we're short on time today, but really wanted to show that these programs just reflect our commitment to meeting people where they are. So whether that's a church parking lot, a community center, or a rural health clinic. We believe that by addressing access gaps in preventive care, we can really improve health outcomes and reduce long-term costs for the entire system. So I appreciate your all's time and happy to answer any questions.
Thank you, Whitney. Can you go into a little bit more detail for each of the programs that you chose for that slide? I know you mentioned that the mobile clinic is at no cost. I'm assuming the other 2 are also no cost to members, correct, or policyholders?
Yeah.
Can you tell me where or whom is picking up the cost for those?
Sure. So with the mobile mammogram, we heard directly from providers, especially in rural areas, just the lack of transportation access for some of their patients. It's an hour or more to get to a local imaging center, and there could be a wait for some appointments. So the thought was to bring the mobile mammogram unit directly to their parking lot. They're the trusted resource in that community to call and schedule patients. So UHC is covering that cost for the mobile unit. It includes a driver and a mammogram technician. So no cost to the clinics and no cost to the patients.
Okay. Any other questions from members?
Yeah,
Go ahead.
Okay, so we had kind of addressed to our friends at Anthem about the importance of offering additional nutritional supports, even if you're not on that perhaps A1C of 8, or how are you offering that to other of your insured, as well as the question I think that came up. What about prevention around nutritional supplements, that those might help a person get ahead if you've done the screening and you see some deficiencies? How are you offering those supports?
Yeah, thank you for that question. I loved that first presentation with One Cross, and it definitely had made a note to go back to our teams and research more for what we're covering in terms of supplements for that specific target population that they were talking about. In terms of providing information for example, the that we gave today, we do also offer kind of step-down programs. So this one specifically for the home-delivered meals. You know, a meal is directly delivered to them, refrigerated, they warm it up. Versus kind of a step-down is getting a grocery benefit card to empower them to go to the local grocery store, purchase those foods themselves. We also offer an over-the-counter benefit card that also could be used to purchase foods as needed too.
Thank you so much for your testimony. We appreciate it very, very much. All right, we'll call Molina Healthcare to the table. Ryan and Kelly, if you would, make your way forward. And I'm actually, just due to time, we are not going to take any more questions from our task force, so you guys will get off the hook taking any questions from us, but you still need to shorten your testimony by a little bit. So, Ryan and Kelly, please introduce yourself, and you may proceed.
Great, thank you. Thank you, chairs and members of the committee. I'm Kelly McGivern, Vice President of State Government Affairs. We appreciate the opportunity to join you today, just share a little bit with you about what our team does every day to support our members. improve and maintain their health. I am so thankful to work for a company whose founder was an emergency room physician who 40 years ago decided he would dedicate his life to helping individuals on Medicaid avoid unnecessary costs, especially in the ER, and break down barriers to preventing them from getting care. Today, the focus of our mission remains the same as it did 40 years ago. Our team of almost 600 employees are dedicated to helping our members, whether it's a single pregnant mom who's barely getting by and can't focus on her prenatal care, or finding a member living under a bridge who needs help accessing behavioral health services, or helping our member who has diabetes with his food insecurity and keeping his apartment is preventing him from getting his routine care. These stories are the amazing things that managed care can bring to the table. Flexibility to wrap around services for our members that eliminate barriers to care, and to recognize trends and pivot to support the priorities of the Commonwealth. I think you're all familiar with Passport by Molina. We've provided a few slides. We won't go over that today. Today with me is Ryan Sadler, our plan president in Kentucky. Ryan also serves as a regional leader, and he mentors a number of our plan presidents in the southern region of the country. And I'm going to turn it over to Ryan to provide an overview of the innovative programs that we're offering.
Thank you. I'm Ryan Sadler, Senior Vice President of Health Plans at Molina, and oversee the Kentucky market, among others. I do live in Louisville, and appreciate the comments at the opening about the incident last night and the catastrophe there. Within really even within that first hour, my immediate friend group, I've got a pilot buddy that flies for UPS. I've got another buddy of mine in law enforcement, among others in our chat group. Within minutes, we're making sure they're okay, but within seconds thereafter, that cop and law enforcement was in his truck on his way down to help out. It speaks, I think, to the Louisville community and the whole Commonwealth. But then within a couple hours, we had identified every single employee living within the shelter-in-place zone and had verified in text to make sure that each of them were safe and marked accounted for. We do have tens of thousands, if not hundreds of thousands amongst our Medicaid program that live within that same shelter-in-place zone. And so, as you can imagine, we're all working through that to make sure that our members and patients that we serve are safe as well. And then, of course, unfortunately, we'll have to cross-reference the list of injured and deceased to validate whether any or some of those may be our members as well. But our hearts and prayers go out for the communities and the people and folks that have been impacted. So thank you for that. I'm just going to move along quickly to the slides at hand here. These are a handful of demonstrable programs focused on those non-traditional health-related programs. What I would tell you is that most of the things on these several slides are not contract requirements, as you have heard from the other partners today. These are things we invest in because we believe there are health outcomes that come with those. You've heard stories of housing and how we all support that. We have a similar outreach program. Unfortunately, they are too expensive to offer to everyone, right? So we're looking at targeted members where we think there's a quality-driven rationale for why we think this will make a difference in their life, given their circumstance, given their care gaps. Similarly, food is medicine. It's, as we talked about earlier, food is very expensive, and so we obviously can't provide it across the board. But those that have direct gaps where we can tie some data behind why it would be meaningful for them, in particular around diabetes and the like. Of course, that comes with extensive coaching and education, as the senator asked about earlier. Maternal health, this is I would say a call to action. Doula services are not covered in Kentucky. It is one thing we see that adds tremendous value in other states across the country. Some members need that touch. Some members need that wraparound service. We are paying for it, as are a number of others, because we believe it adds value. It keeps, it helps moms to have a longer gestational period, and by extension, fewer and less NICU visits. So where possible, we attempt to deploy that, but that is an expense we incur and not something that the state pays for. Preventative transportation, this is a supplement wrapping around the non-emergent transportation benefit that is already provided. But in some cases, that direct pickup or delivery of the member or the patient to the service site is helpful and what is ultimately the difference in getting it done. Healthcare clinics, we have a number of these around, whether it be through churches, our own satellite regional offices, or community groups that we partner with. But taking those services to the member ultimately moves the needle relative to quality outcomes. Care management here on the right, this is something that is required by our contract, so by extension, part of our admin load and cost that the state pays for. All of us are constantly trying to figure out who is high risk of certain conditions. We target those folks with direct outreach, try to figure out a way to prevent that from happening or slow it down and curb the trend, Healthy rewards, health outcome-based programs. This is more like value-based contracting, alternative payment methods where we can try to figure out a way to get more skin in the game for providers on the other side to the extent that they want to take on risk. We encourage that. To the extent that they want to participate in any gains, to the extent that there are any, we encourage that as well. At the end of the day, the insurance business is about taking risk, and so that's where all of us sit. But it is true, not all providers are interested in that for a variety of reasons. Wherever they may be on the continuum, we are anxious to meet them there. And then diabetes, we talk a lot about just because of the impact on the members that we serve in particular. There are, as you might imagine, there are a lot of members within the Medicaid program that have diabetes and or prediabetes. A lot more to tell behind this, but that is the presentation.
Very good. Thank you so much. We appreciate it. And I would encourage you, if you could, just to stick around after the meeting in case members have some questions for you one-on-one.
Yes, sir.
Thank you so much. Last but not least, standing between everyone in the room and dinner is Aetna. No pressure at all. If you hear stomachs growling.
We'll be brief, I promise.
We're talking about food as medicine.
Yeah, talking about food as medicine. Our stomachs are growling. If you would, please introduce yourselves, and you may proceed.
I'm Dr. Nicole Flora. I'm the Chief Medical Officer of Aetna Better Health of Kentucky.
And I'm Jennifer Knockreiner. I'm the Chief Operating Officer for Aetna Better Health of Kentucky. Thank you very much for allowing us to spend our afternoon with you. We will get you to dinner quickly, I promise. So you've heard from all of our MCO colleagues. You have a pretty good feel for the role that we can play in being sort of upstream from a preventive health perspective. And you'll hear a little bit more about that and what we do within our traditional Medicaid population. But we are uniquely different among MCOs in that we serve both traditional Medicaid and the Supporting Kentucky Youth program, which is sort of a program within a program. So we serve about 25,000 youth across the Commonwealth that are involved in the child welfare system. So foster, former foster, adoptive assistance, juvenile justice involved youth, which requires, as you might expect, a very different strategy and mentality in terms of the types of support those youth and families need. So this is just an overall snapshot of the distribution of those members and what our membership footprint looks like. We skew more rural in terms of our membership, and we serve mostly children. So let's talk a little bit more about SKY. This is very much a behavioral health focused program. You can imagine youth do not arrive in this program through great circumstance. There's a lot that leads up to this. So we assign every youth in this program a care manager. So it's a one-to-one match. So those care managers really get to know these youth. Folks can opt to stay into the program up to age 26. So we do have an age continuum there. But they get their own care manager assessing for physical and behavioral health needs, things like adverse childhood events, which we know are predictors of long-term health outcomes. So what we've found through our work in this program since 2021, you can see on here about 70% of our participants have an ACE score of 4 or more. So that an example of an ACE would be something like physical abuse, emotional abuse, and incarcerated parents. So these are really, really challenging things that we're working to address. So some of the things that we've put in place here to support, we talked a little bit about overprescribing. We found a lot of these kids, when they come into the SKY program, they're on multiple antipsychotic medications, which creates a lot of metabolic mischief, obesity, blood glucose shift. So we round with Dr. Laura and DCBS and the providers to make sure that kids are on an appropriate regimen. We make sure that they're getting the blood glucose screenings that they need, the lipid screenings that they need, and this is an ongoing effort as children change placements and change providers. We're always trying to stay on top of that one. With all of the history in trauma for these kiddos, sometimes weight management is a challenge, so we do a lot of BMI screening, referral for weight management programs and those kinds of things, and keep a really close eye on those quality metrics for nutrition counseling and exercise. We have a robust training program. Maybe some of you have participated in it as external stakeholders who have an interest in this area. We've trained over 50,000 individuals on various topics since program inception. And then we also have some technology supports that allow youth, when they're in the program, to stay connected to their natural supports as they work towards reunification. Let's talk through some of the innovative reimbursements that we have. Like others, we also have medically tailored meals. So we've provided over 350,000 meals since 2023. I think this goes back to, and we tailor these based on chronic conditions. So if you have diabetes, you get a certain set of meals. If you have congestive heart failure, you get a different set of meals. And we do this post-discharge to help with reducing readmission rates. We offer transportation, not just for medical appointments, but for things that would help with workforce development. So if you have GED courses or job prep courses, we will help make sure that you are able to attend those and move yourself forward. We have some digital tools and coaching related to social isolation, which actually is a predictor of long-term health outcomes. So this one's been pretty successful and popular among our membership. We have remote patient monitoring. There's been a lot of conversation about monitoring blood glucose, blood pressure. So we do provide those tools to our members so that they can keep on top of what their biometrics look like. That information is shared with our clinicians, with their providers, so that the whole team is aware of where that member stands. It's kind of like if you try to lose weight, when you step on the scale, it's informative for you to know how to move yourself forward. That's kind of what those remote patient monitoring tools do. And then doula supports. I think Ryan explained that one pretty well. That's another popular one among our membership. Okay, and I will turn it over to Dr. Flora.
Thank you. So we spend a whole lot of time and work on our strategy around preventive care. We are continuing to modify our approach based on additional information we get through collecting information on social determinants of health, and we refine this every year to make it more meaningful to our membership and the communities in Kentucky. To date, though, since 2023, we've had over 26,000 of our members receive incentives, usually gift cards, in response to them completing preventive care visits. For children, 159,000 children and youth have had well child visits annually. That's up 14% since 2022. 172,000 adults have received preventive health visits. That's 82% of our traditional Medicare line of business members, which is exceptional. Over 90% of our pregnant members have received timely, meaning prenatal care, meaning they receive prenatal care in the first trimester, which results in significant improvements in maternity and child risk factors. We've given out 2,100 cribs and car seats to new parents in order to facilitate better outcomes for kiddos. 80,000 early screenings for colorectal, cervical, and breast cancer to reduce the impact of late-stage diagnoses. We work very closely to achieve these things with our community providers. 65% of our members receive care from providers that are working with us through a value-based agreement with the intent to lower cost and improve quality of care and improve outcomes. Through this approach, we have seen specifically a 30% increase in our members with diabetes that have controlled blood pressure. The combination of diabetes plus high blood pressure significantly compounds the risk for cardiovascular disease, heart attacks, and poor outcomes, hospitalizations, emergency room visits, and just poor quality of care for our members. So the providers we work with in the community are doing a phenomenal job moving this needle. We've also seen a 32% increase in members with the diabetes, it was 32%, 30% increase in controlled blood pressure, and we have reached the 90th percentile among Medicaid MCOs nationally for the performance in this. So, kudos to the providers that are on the front lines working with members to achieve this. You can go to the next slide. But we work very hard not just to incentivize members, but to give providers an appropriate support to help them achieve these goals and to get members where they need to be. We have an extensive community outreach program at Aetna. I will not go through all of these, but we have education to support health literacy, which is probably one of our leading social determinants of health around our members, that really training people how to care for themselves, how to understand lab results, how to talk to providers has been very successful for us. Multiple community events and multiple investments in food insecurity across the state. We do support the RAM clinic and Care Mobile Dentistry. We go into different areas of the state, provide health care and dental care. These have been very successful, very well attended. As you can see, over close to 500,000 free medical services have been provided to people in the community, not just Aetna Medicaid members, but community members. And we continue to have them monthly. We have one in November in Warren County, and then our next one then is in Fayette County after that. So thank you very much for your time, and we're happy to take questions after the conclusion of the meeting.
Thank you so much. And yes, if you would stick around afterwards for any member questions. But again, thank you for your testimony. Just a couple of announcements as we wrap up today. To our members, you will be receiving an email from the task force staff inviting you to submit any type of recommendations that you've heard during this interim throughout the task force, anything that you are thinking possibly could be some great legislation, and anything that possibly you would like included on our final report to LRC. In our next meeting, December the 16th at 9 o'clock in the morning, we will be talking about all of those. We'll be voting on those and compiling that final report for the task force. So please get your recommendations in as soon as you can. So as soon as you get that email, please don't wait to get your recommendations in. So if there's nothing else from our staff or from members, we're adjourned. It's dinner time.